So recently I was reading this book. This is AIOS Ready Reckoner in Ophthalmology, and I was reading this chapter that what causes the shallowing of anterior chamber during phacoemulsification and how to prevent it. Of all the people, especially the beginner surgeons like who are doing phacoemulsification, shallowing of anterior chamber is essentially a nightmare for them. Um, in my case, if I'm operating any case and the anterior chamber becomes shallow, matlab, I sometimes used to get panic attack, what to do, how to manage it. So they have explained it in a very nice way that at what stage of phacoemulsification the chamber is becoming shallow. The first is it during hydrodissection? So just imagine that the pupil is very small and or the axis that you have done, that is very small, and if you are doing copious hydrodissection, in such case what will happen is that the fluid which is going below the anterior capsule, that will collect behind the capsule, that will not behind the capsule, behind the lens, the posterior part, है ना. जैसे ये pupil है, यहाँ से हम hydrodissection कर रहे हैं, तो the fluid wave it will collect behind the lens between the posterior capsule, and this will cause pressure and the lens will move up, and this will cause a shallowing of the anterior chamber. And in severe case, this same situation will lead to what are the capsular blowout syndrome, that the posterior capsule will rupture and the nucleus might drop into the vitreous cavity. So what to be done, that use small amount of fluid for hydrodissection, and always push the nucleus after you have like push the some amount of fluid below the anterior capsule, then tap the nucleus so that the fluid will move out from the other direction. The second thing is that if the cannula is malpositioned, normally where are we supposed to put the cannula? We are supposed to put the cannula below the anterior capsule and above the nucleus. But if it is above the rex's margin, so where the fluid will go? The fluid will go into the Burgess space. It will pass through the zonules and it will go behind the lens, behind the capsule in the Burgess space, and that will create a positive pressure and the nucleus will move up. So if there is any disruption in the zonular integrity, like in the pseudoexfoliation syndrome or in cases of any old ocular trauma, this type of problem will increase. So recognize such situation and make sure that you hydrodissect in the capsular bag only, not above it. Second is that if there is shallowing of the anterior chamber during phacoemulsification of the nucleus, that hydrodissection is done, you have rotated the nucleus, now there is phacoemulsification. You are doing phacoemulsification and then there is the shallowing of the anterior chamber. So what will happen is that there is something called as surge. Now what surge is? When the outflow from the eye is exceeding the inflow into the eye. आँख के अंदर जो पानी जा रहा है वो कम है और आँख से बाहर जो पानी आ रहा है वो ज़्यादा है. So there is a disbalance between the inflow and the outflow, and this phenomena is called as the surge. So whenever the surge happens, the anterior chamber becomes shallow abruptly, and it might lead to touching of the phacoprobe with the endothelium or with the nucleus or with the posterior capsule, and can lead to complications. But with the newer available machines, this problem of surge has decreased to a great extent, and we are not facing surge with the higher end machines. Secondly, if you are using iris hooks, so when you are using iris hooks, you tend to make 4 tunnels now. So from these you will pass the hooks and they tent up the iris, and they also act as a tract or a pathway for the outflow of fluid, and they also causes what shallowing of the anterior chamber. So keep in mind that whenever you are making whenever you are making tunnel for the iris hook, use smaller tunnels and with a very long length. The size of the tunnel should be small, but the length should be long so that it does not leak. Okay, one important thing that most of us they ignore is that we use a very tight speculum. So that tight speculum also causes positive pressure from the eye. So keep in mind that If you are using a very tight speculum and then there is a shallowing of the anterior chamber, then uh, just give an attempt or just try to lose the speculum and continue with the surgery. All right, now let's talk about a very devastating complication, that is suprachoroidal effusion or hemorrhage. If such things happen, this also causes a very hard eye and the shallowing of the anterior chamber. Now, what causes suprachoroidal effusion? When there is a rupture of the short posterior ciliary vessels. So what will happen is कि vessels rupture हो गई है, there is the short posterior ciliary vessels are ruptured. So what will happen is there is outpouring of plasma and blood into the suprachoroidal space. Now there is blood in the suprachoroidal space that will apply pressure on the eye, and there is the shallowing of the anterior chamber. Um, if if the patient is hypertensive and you have suddenly withdrawn the phacoprobe or the IA probe, this can lead to suprachoroidal hemorrhage, because when you are suddenly removing the phacoprobe or the IA probe from the eye, there is sudden hypotony, and this hypotony is the driving force for damage to the short posterior ciliary vessels. So now when you look at the eye through the microscope, the glow will be darker, the chamber will be very shallow, and you will see a tented mass up at the posterior pole. Acha, what you should not do is never try to convert it to an extracapsular cataract extraction or an SICS surgery, because it will destabilize the globe, and this effusion of yours can convert into suprachoroidal hemorrhage or an expulsive hemorrhage, and that will be a lost eye. So at the end they have given some pearls, and that is, if there is a pre-existing shallow AC, maybe because of the cataract is hypermature or maybe because of short axial length. So what you do is you use a strong cohesive OBD so that there is enough space for you to operate. Second is construct your wound very skillfully, very nice incision so that there is no excessive fluid leak during surgery. If there is a sudden intraoperative shallowing of the anterior chamber with rise in IOP, so think of two things. First is fluid misdirection syndrome. Second is suprachoroidal hemorrhage. So that finishes the chapter. Hope you have understood at least something which is useful for you. See you in the next video. Bye bye.